Hey guys, my name is Naomi. I am a WGU nursing student, and this is my psychiatric medication study guide. So I created this list because psych medications are a whole other monster, and I'll be going over the class of antidepressants today. So I want to get started and say that antidepressants were originally intended to treat disorders that were thought to be caused by too little serotonin in the brain. So the purpose of antidepressants typically is to increase the level of serotonin in a patient's brain. So, with that being said, antidepressants treat disorders such as depression, major depressive disorder, dysrhythmic disorder, long term treatment of anxiety disorders such as obsessive compulsive disorder, post traumatic stress disorder, and phobias. Bulimia nervosa, premenstrual dysphoric disorder, PMDD, BPD, borderline personality disorder, obesity, smoking cessation, and alcoholism. So, with that being said, that antidepressants it typically increase the serotonin in the brain. It can cause a deadly side effect, actually adverse effect, called serotonin syndrome. This is life-threatening and can occur when SSRIs are taken in combination with any other medication, such as TCAs, SNRIs, MAOIs. But serotonin syndrome can happen on its own with any antidepressant, with any antidepressant. Um, but it can also, it's even more risky with other medication combinations, and there are just medication combinations that you do not want to do, like MAOIs and SSRIs, and you want to give a 2-week period, but we'll discuss that later. One of the major tips for serotonin syndrome in comparison to the other adverse side effects from other psychiatric medications that we will discuss is the autonomic instability. So you'll see things like hyperthermia, hypertension, myoclonus, mydriasis, overactive bowels, mental agitation, rigid muscles. And so if like you're looking at the chart, the patient comes into the ER and they're taking an SSRI in combination with an MAOI, and their blood pressure is normally, let's say, 118 over 70, and they have blood pressure that's 180 over 140, and they're agitated and they have really rigid muscles, you could really suspect that they have serotonin syndrome and they need to be treated with the antidote of cyproheptadine, which competes for the serotonin receptors in the brain. So just remember, guys, any antidepressant can cause serotonin syndrome. Serotonin syndrome typically happens over a slow period of time. Serotonin syndrome can happen rapidly, but most likely it's going to happen over a slower period of time. As the patient continues to take the antidepressant, the serotonin will build up in the brain and you will see an onset of these symptoms. So let's just talk about a few major overviews for antidepressants in general. So, the most common side effects with antidepressants, any antidepressant, is an anticholinergic side effect. This includes dry mouth, blurred vision, constipation, urinary retention, tachycardia, and possible confusion. This can make the patient not want to be compliant with the medication, especially if they're not seeing results within the first 2 weeks and they're constipated. Teach the patient to chew sugarless gum, especially for the first 2 weeks of starting this medication. Teach them to eat an adequate amount of fiber, drink an adequate amount of water, and exercise. This is super important to help combat those anticholinergic side effects. And here's a big one. Anticholinergic side effects should dissipate in 2 weeks. And if they don't, then the patient needs to talk to the PCP. Um, these are a little out of order, but you should know in general that antidepressants, this is way broad and way general, but antidepressants can take 1 to 6 weeks before the patient will see any effect in mood. Most antidepressants are right on that 3 to 6 week line, but some antidepressants take only like 1 to 3. So that's something that you really want to know specific, and they're typically pretty specific for the class. Like TCAs work a little bit faster and MAOIs work a little bit faster than SSRIs. But a general rule to follow is for any antidepressant is they take 1 to 6 weeks before the patient will notice like a better mood. And they might notice a better mood in 2 weeks, but it might not reach like the full effect that we really want. So we need to make sure to give it time. Um, and remember that these do not cure depression. So remember that we don't want to give the patient false hope and say, you'll be fine when you take this medication. That's not the point of antidepressants. Remember that the point of antidepressants is to treat the physiological symptoms of depression, such as feeling down, such as not being able to sleep at night, thoughts of suicide, those things that depression causes. If the patient just lost their loved one, which is often a trigger for depression, it can't cure the sadness or the feeling of loss from that. It can only treat the physiological symptoms. So going back to the risk for serotonin syndrome, a huge one is concurrent use of St. Johns Wort can increase the risk for serotonin syndrome. So St. Johns Wort is a herbal remedy that people use on their own to treat depression. So you always want to screen your patient and say, are you taking any herbal supplements? Because if they're taking St. John's wort and then they start on an SSRI, they're at risk for serotonin syndrome, and this could be very, very, very dangerous. So just keep that in mind. So another large implication with people is, let's say you're treating a patient who has MDD, so major depressive disorder, and we're treating them with an antidepressant. So when people have MDD, they have the most suicidal ideation. It is not where the most suicide attempts occur. The most suicide attempts occur in moderate depression because people feel good enough to kill themselves. They have the energy to kill themselves. So as a patient, if a patient is in in-home care and they have MDD, it is important to teach the family and the patient to call the physician with any suicidal thoughts. And this can happen with any antidepressants, TCAs, MAOIs, SNRIs, SSRIs. Guys, if they are on an antidepressant and they have MDD, they need to be monitoring themselves for suicide. Okay, this is huge. You need to educate the family. You need to give them the suicide hotline number. You need to give the patient the suicide hotline number. You also need to just tell them to come into the emergency room. Suicidal ideation or considering suicide is an emergency. It's a life-threatening emergency. So the patients need to report that right away. Another large patient teaching is antidepressants can cause sexual dysfunction. They can cause ejaculatory disorders, so where the patients can't get off, or they can cause sexual dysfunction and the patient doesn't have the ability to get an erection or become aroused. This is really common with the use of SSRIs. It's so important to teach the patients this because imagine being depressed, you get this medication, it's not working, and then you can't even enjoy sex. So it's super important to teach patients that sexual dysfunction is common with the use of SSRIs. Another large implication, guys, is do not mix SSRIs with lithium. Lithium is a very special medication in general, and when you start mixing stuff with it, it's not good. So SSRIs and lithium are not okay. So let's move to the first class of antidepressants, which is SSRIs. And this is the first line of defense. This is where most physicians go right away. So if somebody is newly diagnosed with antidepressants, you can expect them to be on selective serotonin reuptake inhibitors. And I highlighted a good list of them. Just note that a lot of psych medications in general, including antidepressants, you um, can cause seizures. So a lot of them lower the threshold for seizures, or a lot of them can produce seizures in patients who don't have seizure disorder. So that's something that I would pay attention to is are these medications dangerous for patients with seizure disorders, or can these induce seizures in patients who have never had seizure disorders? Also pay attention to if the medication, like Zoloft, can induce or increase anxiety. That one is huge. So a patient may have an onset of anxiety when they start taking an antidepressant. It's not good, but it's not life-threatening. They might want to report it to their physician. It's just that one, if it goes away, keep track of that. That's a big one. Know if there is anti-anxiety, if it produces anxiety. Sorry, excuse me. Another large thing that I would pay attention to is a patient can experience photosensitivity with a lot of antidepressants. So teach your patient to wear sunscreen and use protective clothing. So pay attention to photosensitivity if the medication can induce anxiety, and if the medication either produces seizures or reduces the seizure threshold for patients with seizures. A lot of these medications, too, um, can do hard stuff like Celexa can increase QT prolongation, which can be deadly. I would also pay attention to can this medication be given to patients who have schizophrenia? Can this medication be given to patients who have bipolar disorder? Because they can actually increase episodes of mania in some patients. So atypical antidepressants, you have Wellbutrin, Buprona. Oh my gosh, guys, I can't say it. Just Wellbutrin. Um, this one is something that I really want to talk about, which is Abusebar, which is buspirone. This is a safe medication to give people as a anti-anxiety because it is non-addictive. But a patient cannot take grapefruit juice when they drink this, so this is a medication that is fine for people who have had addiction. SNRIs, I highlighted this again. Okay, let's move down. I haven't really ever noticed much of NRIs, selective norepinephrine reuptake inhibitors. Actually, except for Strattera, which is a treatment for ADHD in children, which is not yet approved for depression yet. But let's talk about tricyclic antidepressants and what's really important with TCAs. TCAs are lipid soluble and they are rapidly absorbed. They come with a huge suicide precaution because they are rapidly absorbed in the fat. Just like vitamin, you can get toxicity. So patients are typically only sent home with a small amount because they can easily overdose. They can kill themselves. This is not good. Um, be cautious with TCAs. Most TCAs make patients sensitive to UV rays. Again, teach them to wear long sleeve sunscreen. May cause daytime drowsiness. This is a big one. Patients on TCAs should take them at bedtime. TCAs have toxic blood levels. Anything over 1,000 NGs per ml can result in sedation, ataxia, agitation, stupor, coma, respiratory depression. Okay, this is what that should be highlighted. If your patient takes TCAs and they haven't had a reaction, what can happen is they can have a cardiovascular reaction, can become days later, which is not good. So you want to monitor their EKG if they have taken an overdose of TCAs. So let's move on. So, and then a good way to remember TCAs, guys, is most of them end with L-I-N, I-N-E, 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 I-N-E. And then the antidote for TCAs is sodium bicarbonate. So, this is the most important one, is sodium bicarbonate. And then there are MAOIs. These, I don't know why MAOIs are my absolute favorite. So this is the type of antidepressant that I was talking about, that it is unique because it targets multiple neurotransmitters, including serotonin, norepinephrine, epinephrine, dopamine. They're atypical, and they're usually used to treat depression that is resistant. I mean, difficult depression. Guys, this is huge. Just don't take any other antidepressants with MAOIs. SSRIs are a huge one with this. Patients on SSRIs need to wait 2 weeks, before they can begin taking MAOIs, guys. It's 2 weeks, okay? Patients need to wait 2 weeks before they can take MAOIs after they've been on SSRIs. This can induce serotonin syndrome again. Patients should avoid aged cheese and wines, aged meats, yeast organ meats, because this can induce a hypertensive crisis. Warning signs, MAOIs, warning signs with MAOIs, blood pressure, palpation, headaches, all that stuff for the hypertensive crisis. I have that double mentioned. You might see things like occipital headache, face feeling full, chest pain, sweating, fever, nausea, dilated pupils. Um, and then you want to use IM chlorpromazine. Oh my goodness, guys, don't kill me. To reduce the hypertensive crisis. Just remember that most MAOIs do cause hypersensitivity. And then when patients are taking MAOIs, know that drinking too much caffeine can also cause a hypertensive crisis. So encourage your patients to reduce the amount of caffeine intake or not to increase the amount of caffeine intake. Selegiline, guys, I have seen this medication quite frequently come up. Okay, The granulocytosis is very unique. Know that is a low white blood cell count, and that is deadly. I also put ECT for electroconvulsive therapy. Electric convulsion therapy. This is typically a last resort for patients with MDD who are non-responsive to antidepressants. This is also the most popular treatment among the elderly population because of their common resistance to antidepressants. Also, although it isn't a pharmacological treatment for depression, this is still a medication intervention that must be prescribed by a physician. Grand mal seizures, this treatment happens and the patients are put under anesthesia, so the patients have to be in PO at midnight before the procedure, and they induce grand mal seizures while the patient is under anesthesia. So the patient does not feel any pain. It's really important that we allow the family members to voice their concerns or the myths that they've heard about ECT. It's also important that we explain to the patient ECT in simple terms that they can understand. Also, remember that the patient may suffer short-term memory loss, but it's the nurse's job to help the patient remember what it was like before surgery. Remember that the nurse wants to continuously monitor vital signs during ECT and after. And then when the patient wakes up from the surgery, it's important for the nurse to orient the patient to time and place. And then just a quick one for antidepressants and children. Antidepressants used to treat children come with a black box label for increased suicide risk. It's huge. The only antidepressants approved currently for children are fluoxetine, and those are for children 8 years or older, and Lexapro for children 12 years or older. I'm just going to go back through this list and make sure that I didn't miss anything that would really be super useful. So remember that the antidote for tricyclic antidepressants is sodium bicarbonate. Tricyclic depressants are absorbed in the lipids, so they can be easily overdosed on. Know that MAOIs are typically for atypical depression. They're not like a first line of defense, and they are used. Oh goodness, I lost my train of thought. Excuse me. In like resistant depression, that MAOIs and TCAs are a big no-no to mix other medications with in general, other antidepressants in. Know that MAOIs can cause a hypertensive crisis. Know to put your patients with MDD on suicide precaution. Guys, I would also pay attention to what medications are safe to give while breastfeeding. Again, the antidote for serotonin syndrome, which is life-threatening, is cyproheptadine. Um, if you have any questions or any comments about this, please let me know. I hope this was helpful. If you're not added to this list, again, please drop your WGU email below. I hope this gives you a better idea and an overview of how to study for antidepressants. I hope you guys have a good day and good luck out there.